So we go on to our last set of talk, which is IUL with intravitreal steroid versus IUL without intravitreal steroid in management of complicated cataract post-uveitis. And we have talking on this Dr. Ketan, who's a vitreoretina consultant practicing at Nagpur Apollo Clinic. And we have talking against it is Dr. Tennerson, who's a consultant vitreoretina services and Uvea at the Eye Foundation group of hospitals. So,
good evening, everybody. Thank you, Dr. Chitra, and I'm sorry for the delay. And the members of the ARC for this wonderful learnings over the course of these debates, which actually happen in a clinician's head every time we see these patients in the clinic. I appreciate the opportunity to be a part of this forum. The topic that I'm speaking today is about uveitic cataract surgery with or without steroids. And I would be giving my arguments in favor of using intravitreal steroids for cataract surgery in uveitis patients. Uveitic cataracts and their managements have always been a double-edged sword. Cataract causes a drop in vision, but the cataract surgery itself has its own perils, most feared amongst which is the recurrence of inflammation. Around 1 in every 8 patients would have a recurrence of inflammation in the first month itself, while almost half the patients show recurrence by the end of the first year. Second complication is about cystoid macular edema, which happens in about 30 to 50% of these patients. Along with these two, other vision limiting complications that an early PCO formation, IOL deposits, as well as an ERM formation tends to happen in these patients. So it's clearly a regular run-of-the-mill cataract surgery is not going to cut it in these patients. So in these patients, especially in these patients, steroids come to our rescue, with perioperative steroids playing a major role in limiting the vision deterioration in these patients. To some extent, whether now the question arises whether we go for the systemic steroids or the local depot steroids. So let's objectively judge each of them on the 3 parameters that ensure better quality of vision to the patients: the improvement in vision, the recurrence of inflammation post-cataract surgery, and the cystoid macular edema. And lastly, but importantly, what is the price that the patient pays in terms of side effects for using these treatment modalities? And coming to the first parameter, Okravi et al. Showed that 89.5% of these patients achieved a better visual acuity of 20/40 or better with IVT. Well, Dada et al. Compared IVT as well as systemic steroids and showed that 75% achieved 20/40 or better vision with IVTA as compared to 65% patients with systemic steroids. The next parameter is recurrence of inflammation, especially in the first 3 months, which is the critical period post-cataract surgery. We can see a massive 56% of the patients recurring which are not on perioperative steroids, as was also seen in the first slide. However, it is here when IVTA truly shines, because in patients who received perioperative IVTA, the chances of the recurrences of inflammation within the first 3 months is almost 0, while with systemic steroids, it is more than 20% in the first 3 months. Coming to the next parameter, the cystoid macular edema. CME is the most common cause for unimproved vision post-cataract surgery. Rosette et al. Found that IVTA is more effective in preventing cystoid macular edema compared to oral steroids or even orbital floor triamcinolone injections. Now, having studied the 3 performance parameters, IVTA comes across as a better option across all these parameters. Well, coming to the side effects, let's discuss the systemic steroids first. The list is literally exhaustive, where I can just list all the complications of systemic steroids for the entirety of the 6 minutes that I have. Prominent among these include weight gain, deranged sugars, gastric ulcers, osteoporosis, and the list keeps going on. When it comes to intravitreal steroids, let's address the elephant in the room: IOP rise post-IVT. This fear of IOP rise is what deters most surgeons from using IVTA, and rightly so, as I'm sure all of us must have dealt with steroid responders in our clinic at some point or the other. So the question is not whether IOP increases or IOP increase happens post-cataract surgery. Yes, it does. The question is, we need to understand whether the IOP, the benefits that the IVTA gives, do it supersedes the benefits of the IOP rise. Does the three parameters that improve with IVTA supersedes the risk of an IOP rise? So coming to the IOP spike, when it comes to intravitreal steroids, yes, it leads to an about 25 to 26% of these patients show an IOP increase, as compared to systemic steroids, where around 6% of the patients showed an IOP spike. Even in Ozurdex patients, the IOP spike was comparable to those of the IVTA patients. I would like to take you to a slightly more busier slide than this. This table shows multiple studies evaluating IOP spike post IVT. And as we discussed in the last slide as well, all of these patients show about IOP spike between 25 to 50% of the patients show IOP spike. But I would like to draw your attention to the column next to it, that the patients who did not respond to medical therapy, they form a very meager 1 to 6%. That's it. So it's about 95% of the patients will not require glaucoma filtration surgeries or any surgical interventions and can be managed on just anti-glaucoma medications. But one may argue that what about the cost of long-time anti-glaucoma drugs or the quality of life that may get affected because of this anti-glaucoma drugs? So when we look into it, the duration of ocular hypertension is just about 1 to 9 months, following which the IOP comes back to normal. The maximum IOP rise happens between 2 to 12 weeks. Even these anti-glaucoma medications can be completely discontinued by about 8 months. There was not much difference whether you give 2 mg or 4 mg steroids. But yes, the duration of anti-glaucoma medications become a little longer with 4 mg group. So during my literature review, I realized that fear is nothing but incomplete knowledge. We do not need to be afraid to use IVTA in uveitic patients, as in my opinion, the benefits far outweigh the side effects that happen with IVTA. I would sum up with this last slide. Systemic steroids is effective, no doubt, but IVTA is better in almost all comparable parameters as compared to systemic steroids. On top of that, systemic steroids act like a weapon of mass destruction, while intravitreal steroids are more precise. And with the addition of this, they become extremely safe too. Thank you.
Wonderful talk, Dr.